Good morning, everybody. So what we are going to talk about is, I'm going to start talking about contextualizing the role of behavioral science. What does a behavioral scientist specifically, how can contribute to global health initiatives and sustainable development goals challenges, because it's a huge challenge. As you know, the achievement of SDGs are, at this moment, a disaster. And we have to be aware of that, okay? Throughout the world, none of the goals are being achieved. So we have a huge challenge ahead of us. And I think as global health practitioners, scientists, we have to be very attentive to that. The SDGs are far, far, far away from being achieved. So it has to be accelerated, it has to be facilitated somehow by interdisciplinary disciplines, okay? So this is one of our concerns about it. The second point I'm going to share about my professional experience in behavioral science interventions, particularly in the healthcare sector in Brazil, in the biggest hospitals network in Brazil. And I'm going to talk about three tools that behavioral science can contribute to accelerate the global health initiatives and helping to achieve SDGs. So the role of behavioral science is in the context of global health systems. First of all, just to understand a role of behavioral scientists, in 1973, it was published in a very important scientific journal of psychology, the beginning of the competence movement. So that's where it started, competencies to be enumerated and based on research. And by David McClellan in Harvard University, he had a PhD student called Richard Boyatzis that started a research program about competencies together with management. So he was the first researcher in history to enumerate a number of competencies of management together with behavioral competencies in management. And he published a very, very crucial book called The Competent Manager in 1982. So he's the leading researcher in competence in organizations. He was somehow my mentor in the past 20 years. And he started to link the behavioral competencies to the management competencies in organizations in the beginning of the 80s. And then came up the idea to include that in business schools. So all the idea of organizational behavior started to get into the business schools because of his research. So what he started to show is that the behavioral competencies are the differential point for managers. If you have two samples of competence management, what makes high performance and makes the difference in terms of performance are the behavioral competencies. So he raised the importance of behavioral competencies in organizations, in all types of organizations. So his research is really, really important. And making a context about the World Health Organization, you see, I'm not showing anything new to you, just to have you an idea that you have service delivery, human resources, medicines and technologies, finance and information, and then you have in the center the leadership and governance. I would add something else, which is called organizational change or systems change, which is much bigger and broader than leadership itself. So together with leadership, we have to learn and make research to understand better ways to change organizations. I don't know if you have any idea about it, but 80% of organizational change fails. It's a huge failure because there are some classic mistakes that all the people that are responsible for changing in organizations or changing systems, they usually make. And this area of research, organizational change, is a scientific area specifically of behavioral science, particularly organizational psychology. Okay? So you have three groups of competencies. You have a behavioral competencies in the middle because it's transversal. You have technical competencies. You have, for example, in a hospital, you have medical doctor degree, specialties, all the technical areas of expertise in a hospital. It's called the technical competencies. And you also have management competencies. But the most transversal type of competencies are behavioral competencies, because together with all technical competencies, you always attach a behavior. So most of the problems of organizations have to do with behavior. Individual behavior, group behavior, and systems behavior. That's why organizational behavior and behavioral science are so crucial to that. And sometimes organizations and managers and leaders don't realize that. They make the mistakes and over again because they don't understand the group behavior mistakes that they made. They make the technical stuff, they're worried and concerned about the technical excellence, but they make basic behavioral mistakes in the processes of change. That's why we enter as behavioral scientists, as behavioral specialists. So let me talk about my experience in behavioral science interventions in Door Hospitals Network. It was a very curious experience because my initial motivation to go into Brazil was to get into a neuroscience lab. I have a background in organizational psychology, and my initial interest was just to get into a neuroscience lab, learn a lot of fMRI. They were just launching a neuroscience unit together in partnership with Stanford University, which I loved. I was part, as an experimental psychologist, of a team of mathematicians, neurologists, physics, and all the stuff, very technical stuff about social and cognitive neuroscience. I was the experimental psychologist responsible for in this team to launch the first PhD in social neuroscience in South America, Brazil. So my initial interest was just research. But I had already a lot of experience in Europe, in the biggest training company in Europe, headquartered in France, in training and development. And I have brought, before that, a lot of courses from the best universities in the United States for Europe, for the European market at that time. And when they saw my CV, they said, oh no, I'm not gonna let you just make research. We're gonna create a training academy for the whole network. And it was a huge organization, 70 hospitals. So they made me responsible of the academy. And I said, why are you hiring me? Because you are a specialist of behavioral competencies. And that's our problem. We have the best medical doctors. Most of them had PhDs in Johns Hopkins, Cleveland Clinic, and other very, very famous institutions in the US. But they had a lot of behavioral problems in the organization. So I said, okay, I don't have experience in leading a very big academy, but let's gonna try. And then I entered as the director of the academy, together with research in social and cognitive neuroscience, 70 hospitals, 555 oncology clinics, 71,000 employees, plus 87,000 accredited physicians. It's a lot of people, right, to train. 11,512 total beds, 5.3 million emergency responders. So it's a huge endeavor. So how we started? We started to prioritize starting with a leadership development program for, this is the EDOR, which is the research institute inside the hospitals network. That was also the academy, the headquarters of the academy, training academy. This is the real photo of my colleague, a physics responsible for the fMRI, scientific collaborator. And we started planning the first leadership development program. So each training had 6 months. We started with in-person training, 3 to 4 intensive days, and then measuring their development. We made leadership development plans for each director of each hospital. And we started making individual developmental plans for each director of each hospital and all the leaders of the sectors. And of course, I hired a huge team. I even hired a guy from specialist in organizational behavior in Portugal to help me, because I didn't have that know-how in Brazil at that time. I'm going to explain in detail the leadership program later, which are one of the tools for the global health. So I also developed a model of emotional intelligence for excellence in patient care. This is very interesting, because the owner of this company is a cardiologist. And he said to me, okay, we are having trouble with the nurses in the emergency room of our biggest hospital. Could you prepare a training for them, for nurses? And I said, okay, but let's just measure what is the perspective of the clients, the patients. So I started measuring the feedback of the clients, of the patients, in the perspective of them about the reception, the nurse assistants, the nurses, and the doctors in the emergency room of this hospital. Do you know what I found? Most of the complaints weren't about the nurses, were about the doctors. The best surgeons in the country, they were really bright, brilliant guys, but they were terrible dealing with the patients in a behavioral way. And that was not my opinion. It was the patient's feedback. So we started creating an ongoing measurement about, on the patient's perspective, about all the lines of attendance in the emergency room. And the best ones were from the reception. They have a lot of low technical skills, right? But they were the best in terms of behavior, dealing with the patients. And the patients reported that they loved them. They were happy. So I had to design a specific training course about emotional intelligence for excellence in patient care for the medical doctors. Fortunately, this course had already been created by Richard Boyatzis in Case Western Reserve University. And do you know what is in front of Case Western Reserve in Cleveland? The Cleveland Clinic. So the first training about excellence in patient care was designed by Richard Boyatzis to the Cleveland Clinic. And still today, they make this course for the medical doctors. And what I just did was, I had already been before a student of Richard Boyatzis. I brought all the leadership with emotional intelligence to the Portuguese market, to the European market, and then to the Brazilian market. And then I designed the course adapted to the medical doctors. And the result was fantastic. After that, we measured the evaluation from the patients, and they were really, it was very different, the evaluation in terms of patient care. So it was a pilot project of one hospital, specifically in the emergency room. And then we migrated for the 70 hospitals, starting with the emergency room and then broadening to all areas of patient care, which is a huge endeavor. So first lesson, never assume which area has the problems, because he was a medical doctor, the owner of the company, and the nurses was okay. So you have to measure every time the perspective of the patients. So it's a patient-centered organization and patient relationship-centered organization. That's the idea, for example, of Cleveland Clinic. That's why Cleveland Clinic is so excellent, because they really take care about the relationship. I was there once in Cleveland Clinic, and I knew even the driver of the bus that drives you there have a lot of training. And I can tell if they have training or not. You can see that, okay? So that's the big first lesson of how impactful can have a behavioral scientist in a technical organization, which is the healthcare one. So I also provided excellence in patient care behavioral service techniques for reception, nursing assistant, and nurses, although they were considered, reported as very good. But I found it out important to provide them a structured knowledge of how to deal with patient care in a structured way. I also developed a course of time management of meetings. They were terrible managing the time in meetings throughout the hospital's network. Also presentation techniques for researchers and hospitals directors. Assertiveness, communication, interpersonal relationships, which was a course designed in the University of California, Berkeley in the 70s. Although it was an old course, it was very useful in this organization because they tended not to tell things. For example, the lack of assertiveness made people hide the problems. And most of the problems went down the carpet in the organization, particularly in interdepartmental problems that came up. So they learned techniques called on a communication model called assertiveness, how to deal with interdepartment problems in a very assertive way, not just avoiding on the one hand or becoming aggressive on the other hand. It was very useful to deal with departmental problems. Conflict management. There are two kinds of people that usually don't have conflict management courses. One of them is to avoid conflict systematically, which is bad on the long term. For example, I learned that in China is a tendency, right? From a Chinese told me, is that true? That there is a tendency to avoid conflicts? Yes? So avoidance of conflicts will cause big conflicts in the future. So I have to learn to address these conflicts. Or there are other people that tend to be very aggressive when addressing conflicts. So you have to learn how to do that, to evaluate the type of conflicts that is in question. And there are strategies, and there is a lot of research about it. So there is research also in the University of California, Berkeley, to teach people how to deal with conflicts. Strategies and tactics of negotiation. For example, the hospitals have a lot of conflicts with insurance companies, the health insurance companies. So they had to learn how to negotiate with the health insurance companies. There's a lot of conflicts. So we designed specific courses for the directors, operational directors, and clinical directors to deal with the health insurance companies. Basic negotiation skills and advanced negotiation skills that we brought from Kellogg University in the US, which is one of the best schools in negotiation in the United States. And also emotional intelligence from Princeton University, we're using the model of John Mayer and Peter Salovey, because some medical doctors had a short temper in dealing with colleagues. Some of you guys are smiling because maybe you recognize something in your careers, right? And for example, in this hospital network, the brightest surgeons had the shortest temper. And the challenge was, well, we need them. They are bright, but they cause so much trouble in the organization. How do we deal with that? We need them because they bring patients, but at the same time, they are very difficult to deal with in a behavioral level. So we have to develop emotional intelligence in dealing with them. Okay? And it was very interesting because some of these surgeons attended the course. They didn't have a full-time job in the network because they were freelancers. They had a partnership with the hospital's network. They were the brightest surgeons in the country. And they attended the course. They were curious, to attend the course. And then they find, oh, somehow this is useful, because they usually thought that psychology is BS compared to medical doctor. It was very interesting, this experience. And then we had the appreciative inquiry methodology, which is called positive organizational change. We're going to talk in more detail about that later. And science-based happiness strategies for nursing professionals. For example, for patient care, home care, They had a unit specifically for home care, and I provided training of science-based happiness strategies for nurses and nurses' assistants to teach the patients happiness strategies to increase their well-being together with the treatment. So you have the physical treatment at home, and you learn as much as possible as what you can implement on a daily basis for happiness strategies. And there are already from psychology. University of Berkeley also. So University of California, Berkeley provided the sum of all the happiness strategies to increase the patient's well-being together with the treatment in home care. It was a huge success to increase the well-being of patients and also the nurses. The nurses loved it. They increased their own motivation to get into these happiness strategies. So in terms of behavioral science tools to facilitate and accelerate global health and SDGs, I'm going to talk about 3 tools, specific tools that we can develop. The first one is called large-scale positive social change of systems and health systems. I'm going to talk in detail about it now. It's a organizational change or positive organizational change model developed by Professor David Cooper-Ryder. We're going to talk about systems thinking for systems change and health system Professor Peter Senge from MIT, and a leadership development program. So these are the 3 big tools that behavioral science can contribute to help the healthcare professionals and the healthcare organizations, and also large-scale SDGs acceleration and facilitation. Okay. So large-scale positive social change, appreciative inquiry. Very, very interesting by Professor David Cooper-Ryder. He's distinguished university professor from Case Western Reserve University. He was the former director of the Division of Organizational Development from the Academy of Management. So the Academy of Management of the United States has the Organizational Development Division. And he was the director of this division because he developed what is considered in the academy the best organizational change model that exists so far. Okay? It's called appreciative inquiry. Does anyone ever heard about appreciative inquiry? Raise your hand, please, just to have an idea. Nobody ever heard about it, right? So it was published, the first paper about appreciative inquiry was published in 1985. Just to give you an idea how the areas sometimes do not cross. Okay? Well, the idea of positive organizational change starts with the idea of how management usually works. People tend to see organizations as problems to be solved. What we call problem-solve approach. As a consultant, I'm going to look what's not working well, and let's solve it. So that's the prevalent approach to organizations. In psychology, what we see in clinical psychology is mental illness. What we see in medicine is a disease model, try to diagnose a disease, right? So it's a disease or negative approach to look for what is going wrong. Make sense? And also happen in psychology. That's why in psychology, they developed a new approach, which is called positive psychology, that says besides what's going wrong, there are also a lot of things that goes well, that are unattended, that are not systematically analyzed or taken into account. So usually in organization, you should identify problems, conduct root and cause analysis, brainstorm solutions, and analyze, develop action plan. Most schools, companies, families, and organizations function on an unwritten rule. Let's fix what's wrong and let the strengths take care of themselves. So that's the prevalent approach to organizations. So it causes fragmentation, few new images of possibility. I don't know if you ever conducted a large-scale change, but it's very tiring. For example, an accreditation of a hospital, people get desperate. If you ever saw a process of accreditation of a hospital, I saw many people crying on the corner. I'm not going to be able to do that. The evaluation is coming. So there is a lot of fear of not being able to be up to the task. So there is a lot of negativity in organizational change processes. So there is a lot of negative stuff going on in the process of change. That's classic, okay? So fragmentation, few new images of possibility, exhaustion. The experts must know. So we expect that the experts arrive there and tell us what to do. And usually it doesn't work. If you have the best experts, you have to be engaged in the process. Otherwise, somehow you're going to resist to it. So there is a lot of problems that comes from this standard approach or negative approach of organizations. And that happened to David Cooper-Ryder. Professor David Cooper-Ryder started his PhD process in 1980 in Cleveland Clinic. And he started to, let me just show you, let me just tell you this story about David Cooper-Ryder. He started his research in Cleveland Clinic in the 1980. And he started to, he wanted to understand what was going wrong with Cleveland Clinic, because Cleveland Clinic wanted to change and grow. It was exactly 1980. And the first 3 months that when he entered the organization, started to interview people, he was desperate because he saw so many conflicts and he didn't know what to do. And he asked for help for his supervisor because he was a PhD student at that time. And then his supervisor had the idea, start asking what goes okay, not just what goes wrong with the organization. Because he started to diagnosing the problems. And he got so many conflicts that he didn't know how to start to help the Cleveland Clinic. And then his supervisor had the idea, start asking good questions in the sense that what works well? What are your best practices? And Cleveland Clinic, fortunately, has a lot of good stuff to tell. And when he started to do that, he had an insight. Okay, why don't I create a methodology of change based on systematic discovery of whatever works well for the organization? And why he did that? Because it started to increase energy and positive energy in the organization because it was real. The good things were real. They existed. And then they started to feel energized and motivated for change. And then he had the idea to create what he calls appreciative inquiry. The word appreciative is that I look for the best in you. I start systematic questions looking for the best of each individual, of each group, of each department, and start gathering as much people as possible. So it's the first phase that he calls the discovery phase. Discovery part of the best, of the excellence, of the goodness, of the real experiences of excellence in organizations. That was his first phase. And then after that, people start to feel energized because do we like to talk about our strength or not? We love about it, right? Because it's something we are easy doing. Our strengths, the good things that we did in our professional lives, our talents, our abilities, our real professional good experience that we had, the good mentors that we had, the good projects that we participated in, the good innovations that we participated, the pleasure. So it started to generate a lot of positive emotions in the groups. After that, you pass through another phase called the dream phase. Okay, what are the possibilities? Start dreaming. But don't dream low, dream high. After the discovery phase, you start the dream phase. And you can imagine, for example, what can Cleveland Clinic be 40 years from now? And people started getting crazy, imagining things that were unimaginable at that time, because they were energized about the real discovery, about real experience that they already had. It was a great idea, the dream phase. Don't think about it if it's feasible or not. Just think what you want for this organization for the next 40 years. And that's what they did. The dream phase. Okay, you dreamed a lot. Now let's go one further step, which is design. What do we need? What are the resources we need? Human resources, material resources, financial resources to put in practice what we dreamed about. It is called the design phase. Okay, I mapped and designed, and then I'll go to the destiny phase to start real projects for the next 40 years. And that's how Cleveland Clinic became what it is today. It grew 10 times in these last 40 years. And it's considered the best cardiac hospital in the world. So this is the case study that showed how the Cleveland Clinic, that was facing a lot of behavioral problems, particularly in the relationship between the medical doctors and the board of trustees, which was composed by managers. The medical doctors were upset about the guys that only worry about money in the hospital's network. And look what they did. Look at the history of Cleveland Clinic. And it came from the facilitation of a behavioral scientist. That's the thing most of people don't know. So he was the facilitator of this project. He generated the first big appreciative inquiry of Cleveland Clinic in 1980. It generated a 5-year project that then generated another 20-year project. It didn't stop because they started innovate using the same methodology. 40 years later, the CEO of Cleveland Clinic went to Case Western Reserve telling about how appreciative inquiry was key for the evolution of the Cleveland Clinic. And it was in the healthcare sector. Okay? So you have the normal, which I can call zero. You can have the negative deviance, which is diseases, mental illness, problems, conflicts, right? And then you have the positive deviance. The POS means Positive Organizational Scholarship, which is a research movement started in the University of Michigan, Ann Arbor, in 2004. A group of scholars united, just studying what is best about people. Not only in individual processes, but team processes, organizational processes, and business processes. It's called Positive Organizational Scholarship, University of Michigan Ross Business School. And David Cooper-Ryder was part of that, because the president of the Academy of Management was Jen Dutton, which was the president of the Academy of Management from the University of Michigan, and David Cooper-Ryder was the head of the Division of Organizational Development of the Academy of Management at that time. And one of the big organizations that were intervening was healthcare sector. Okay? So you can study what makes people generous, what makes people have technical performance. How can you increase the performance? There is a lot of research showing that positive emotions multiplies creativity and innovation in organizations. There's a lot. I don't have time to explain in detail, but just for you to have an idea. There's a lot of research that shows that the positive emotions increases creativity, increases productivity, and there is a lot of organizational positive outcomes that comes from positive emotions. And this is really serious research. Okay? And people don't resist change. There was an area of research in MIT called resistance to change, because 90% of organizational change process failed because the people were terrified about change. They didn't participate in the change. They were afraid of the change. they didn't know if they were going to be there after the change, downsizing change, for example. So there is an area of research called resistance to change. Yeah, last year was with Peter Senge in MIT, and he said, people don't resist change. People resist being changed. What's the difference? I don't participate in nothing, in anything. I'm not part of the process. I'm not part of the system. There's a bunch of experts that tells me what to do. And I get terrified. I don't participate in the project. I don't contribute with my best. So the appreciative inquiry is a methodology that starts with individuals, with the best of them. And they can contribute. They're invited to participate in that. Not just at individual level, but in the team level, departmental level, and organizational level. And I have participated in some of the appreciative inquiry summits conducted by David Cooper-Ryder, and the effect is incredible. The kind of positive energy generated is incredible because of the methodology, because it systematically looks the best. That's what matters, right? What can I do? Instead of just looking for problems. Of course, we have problems. But the idea is how do I mobilize people in a positive way? Okay? Peter Drucker, the father of medicine, used to say, the task of leadership is to create an alignment of strengths, making our weaknesses irrelevant. So it's a different approach, right? And another very important thing is that appreciative inquiry also came from the invitation of Kofi Annan, the United Nations Secretary General, that's asked for the help of David Cooper-Ryder. Have you ever heard about the Millennium Development Goals? The Millennium Development Goals were the beginning of the Sustainable Development Goals 15 years later. So in 2004, David Cooper-Ryder was the facilitator of the major business leaders, government officials, and civil society that gave the outcome of the Sustainable Millennial Development Goals. The Millennial Development Goals were the platform framework that then in 2015 were transformed in Sustainable Development Goals, which is the most important framework in an international level, in a global level. It's a mark in the history of mankind. Never, ever mankind united for such global goals, so such global challenges in a large scale. So the seed came from an appreciative inquiry hired by Kofi Annan to David Cooper-Ryder. Okay, so that's how a behavioral scientist can contribute to the large-scale elaboration of a framework that can change the world on a large scale. I made the training of positive organization and appreciative inquiry in 2006, which was applied only to organizations. And then last year, I went to have training for the large-scale social change by David Cooper-Ryder again. So you have the appreciative inquiry applied to only one organization, or you can use large-scale social change for a whole city, a whole region, a whole country, for example. That was the case of a global change, a global platform of business leaders, government officials, and civil representatives to create a global goal. Okay? So I have other case studies to show you, but we don't have time to do that. Let me just show you something very important, which is the model, the discovery phase, the dream phase, the design phase, and the destiny phase. And you reframe a problem through an affirmative topic. For example, if a company has a problem of delivering luggage, you create a topic, how to develop outstanding delivery luggage. So the language is important because it generates emotions. Instead of being afraid of not filling the gap, in a deficit gap, you talk about abundance gaps and look for the strengths throughout the organization to help the abundance gap. So it's a different form of working in groups. For example, he also used that in Cleveland for a project hired by the mayor about the renewable energy in Cleveland. He prepared for 6 months for this event of appreciative inquiry. He brought the best renewable energy experts from the world, particularly in Sweden and Norway, to explain what are the potentials for renewable energy, what can be done technically, and it started for a 10-year project. So he made a very huge appreciative inquiry to change completely the way that the energy is supplied in Cleveland. And he started to change this project with companies from Sweden for renewable energy. And every year they made follow-up using appreciative inquiry. Until now, the project didn't end. So they have a project called Empowering a Green City on a Blue Lake. So he's now conducting interventions in large scale of positive change. Okay? This is a data from the United Nations Global Network. The president is Jeffrey Sachs from Columbia University, the Earth Institute. And as you can see, you only see red, right? Red and orange. As you can see there, you have here good health and well-being, SDG 3. So look at the results. So the United Nations Global Network has the responsibility to provide feedback for the countries of how they are going in achieving the SDGs. And as you can see, you have all Africa is red, South Asia, and South America, Central America, and a little bit of North America. So in terms of SDG 3, global health, the state of the art is a complete disaster. These are the results. This is data. So we have to do something about it, right? And we have to do it fast because we have a deadline in 2030. And we have to do it in large scale, which is a huge challenge for the countries, right? So what can be done about it? Appreciative inquiry in large scale, starting, for example, a continent, and then for each country. For example, you have here the SDG 3, and then you have the 9 targets. Reduce maternal mortality and all preventable deaths under 5 years of age, fight communicable diseases, and so on. So you have a lot of targets already defined by the SDGs, okay? So the targets can be, at the same time, research guides for global health, practitioners and researchers. Because the result of the interventions of research can help to achieve the SDGs. So you are making research and at the same time contributing for a better world in a practical term. And if you have a big umbrella, for example, you have 9 appreciative inquiry working group topics. You spend 6 months preparing for a huge appreciative inquiry financed by international funding institutions with the sponsorship of African Union in a very high level. And then every year you conduct for every African country an appreciative inquiry, only addressing specifically the results for each country, because they vary from country to country. For example, in my experience, Mozambique is one of the most terrible results in terms of health. So reduce maternal mortality and the preventable deaths under 5 years of age. So you can plan and you can involve government officials, you can involve business leaders, you can involve civil society in large-scale events, well prepared, 6 months for one event, that generates hundreds and hundreds and hundreds of projects, global health projects. And we use the positive approach. Where in this global planet are there people that are specialists in reducing maternal mortality? Where are the specialists? What are the infrastructures necessary? Where are the systems that works best in the world about health systems in maternal care? So you can look for the best in the world and invite these guys to be the standard to follow. You see, if you start from the problem, it's much more difficult. But you can invite the best. Where are the best organizations that reduce maternal care? What are the infrastructures necessary? How much does it cost? Which is necessary, right? So you can design working groups composed of the best in terms of this indicator. You can invite the government officials of the country. You can invite the business leaders that have to invest on the international funding institutions and the civil society representatives. And you make a large-scale behavioral intervention that generates, in a phase of destiny, hundreds of projects. For example, I learned from the World Health Organization in Mozambique that the priority is to invest in infrastructure. They don't have hospitals. How can we talk about improving indicators if they don't even have the basic infrastructure, right? So there must be involved infrastructure. And infrastructure can come from the public officials, the public government, but also from the private sector that want to invest. For example, I know a guy from the Department of Defense that are planning to install in Africa mobile production of medicine from the Department of Defense in the US. It's a private sector that can be involved together with the government, making partnerships with the government in global health. Okay. Then you have systems thinking. So you have 5 disciplines of system thinking: personal mastery, that is closely connected to leadership, shared vision, mental models, team learning, and system thinking. For example, you have personal mastery. You can do that through leadership development programs. And shared vision, mental models, and team learning and system thinking can be achieved through, you can bring together people from different worlds. A guy from Sweden that has the best healthcare, together with a government official from Kenya. Start making dialogues and positive dialogues of possibilities. Bringing together these people. And you share a common vision. Create and share in the dynamics of the change process a common vision. Mental models, they have to find a bridge here from the developed world to the developing world. And then team learning and systems thinking. So for each country you can develop, there is a possibility to do that. I know that, for example, the United States aid is willing to invest a lot of money as long as the projects are good, of good quality. Okay. There is a lot of things more to say, but just to give you an idea in terms of leadership development program, because we need leaders to do that. We need healthcare leaders, not only specialized in specific areas that can help to diminish the targets or achieve the targets. So we provide here situational leadership model, training, transformational leadership. I'm not going to explain, it's a little bit technical. Okay, I don't have time to explain in detail each one of the models, but to just give you an idea, we usually take 6 months for a training in situational leadership, and then 6 months later start another model measuring 360 degrees. You can measure the evolution of each leader. Transformational leadership, leadership with emotional intelligence, and then positive leadership. In terms of positive leadership, let me just say one thing. I'm not going to explain that, I don't have time. For the first time in history, there was a guy, a psychologist from the University of Michigan, that made 3 years meetings with 52 the best of psychologists in the US. And they published the first character strengths and virtues classification. So it's an area of research. Virtues that usually in history of mankind was the property of religions and philosophy, now can be an object of science. And Positive leadership is the development, systematic development of virtues applied to leaders. That's all we need, right? We need virtuous people. And we have tools to measure them, to make developmental plans, to help these leaders be the agents of positive change in the context of global health. Thank you very much.
Okay, we have now time for questions from both the people attending online and people who are here. Yes.
Thank you. So thank you for your talk. It's very informative. I wonder, in your working experience, have you encountered any resistance in implementing appreciated inquiry?
Yes, particularly in Latin countries, much more than in Anglo-Saxon countries, because people don't have an idea of what it is. But once they start understanding what it is and the benefits that they can come up with, the resistance goes down. Because one of the magical things about appreciative inquiry is that when we start triggering the strengths of people, people react very well. The problem is to arrive at this stage. So the challenge, for example, David Cooper-Ryder starts the appreciative interview in the beginning of the process. Because when people start, for example, give you a very simple exercise. Think of 3 experiences that you have, that you felt energized, that you felt that you were developing your talent. Some kind of exercises, like very simple exercises, individual exercises, in which people reflect about their talents, the things that they like to do, the things that they know they're good at. So when they start triggering that, people diminish the resistance very, very easily. That's my experience.
Thank you.
Yes.
Hi, thank you. It's very nice to finally get the chance to meet you. So you mentioned, I'm not familiar with the literature of organizational behavior or leadership. You mentioned several competences. So based on my training, we look into decision-making competences. We look into your competence of telling or like stay away from the heuristics and biases, like your competence in terms of being well calibrated in your confidence level. So in our research, we do many interviews with critical care physician or emergency care physicians. The main problem is they are overconfident. Many of their decisions are heavily relying on their prognostication or judgment of will this patient leave or do this patient need to be transferred? And many of them, especially very senior, very experienced physicians, rely heavily on their own experience. Like, I know this patient won't leave. And it's very, very hard for us to design certain behavior intervention to calibrate their confidence to a kind of an appropriate level. Do you have any suggestions?
I know what you mean when you talk about confidence of physicians. They think they are the king of the world, particularly famous surgeons. But if you try to calibrate that with data, hard data, that comes from the patient's perspective and not your perspective, the resistances, they become silent. It can't come from you. I always back myself from the perspective of the client and the patient. Because if I, as a psychologist, say, oh, medical doctor, you're not doing good work, he's not going to like it. Worse, he's not ever going to accept that. But if I provide data from the patient, and the patient pays his salary, it's completely different. So what we try to do is to organize the data the best way possible. We try to make very thorough questionnaires to understand better and to be a sensitive questionnaire about the small issues, the behavioral issues about the way and interaction with the doctors, the nurses assistant and the receptions, and bring the raw data to the medical doctors. That was the only way to convince medical doctors to accept a psychologist just like me, to provide training to them. Who are you to train me? You are a psychologist. I'm a medical doctor. I came from Johns Hopkins with PhD in Johns Hopkins. That's usual, very, very normal. So we usually try to gather data from the patients. That's the only way to diminish his false confidence. Okay. Anyone?
How do you make sure that the changes you implement are long-term and lasting? Because for many of us here, I suppose we can experience that we hear something revolutionary about what to do to make ourselves more effective, and then we implement the change for 3 weeks, and then the change goes away.
Yeah, that's a very important and classic question in organizational change. There are two ways to do that. The first one is, in our case, is I hire, and not only me, but David also has a specialist in follow-up projects. For example, the Destiny phase, I didn't get into detail about that, are assigned a lot of teams. And these teams start designing projects. And you have to have someone following them and providing feedback about how the project is evolving. So the follow-up projects, which is very common in international developmental economics, international funding institutions, 90% of the projects die. So hire in the team of the appreciative inquiry, we have the facilitators, but we also have someone specialized. In my case, I have a colleague of mine that made a PhD in project evaluation. And there is a systematized way to evaluate from time to time the evolution of the projects. The other way to guarantee that the organizational change projects go straightforward is that you can repeat the appreciative inquiry, for example, 1 year later, depending on the types of projects. If you're talking about 10 years, 15 years projects, for example, for the Cleveland project, they every year started another appreciative inquiry, but with more thorough and more specific questions. You can make a global appreciative inquiry, and then you can make, for example, appreciative inquiry of one specific project, because you have to go further into the specific details of this project. So the two ways to do that is to make a cascade effect of appreciative inquiries, smaller ones that go in depth for each project, and also always following the projects itself. So if it is evolving, if it is ongoing, if it is blocking, and provide the immediate feedback. Don't wait for the deadline. You do it during the project. Provide during the project, okay, nothing is coming around from this. You have to change. So provide immediate feedback is the way to do that.
Okay, I also have a question for you, and it's a selfish question. I'm asking you from the perspective of an instructor. You discussed about affirmative inquiry at organizational level and also at the system level, but now I want to ask you at the micro level. For example, how can it be implemented into an educational setting so that the teachers and the students are doing better things together in the classroom?
When you ask about education for one class or for the one university? On a specific class, to be honest, I never heard about appreciative inquiry about one specific class. But what you can do is you can make an appreciative inquiry involving people to make the positive questions about how to improve all the dynamics of the learning process. For example, discover what are the best of the professor's strengths, the best of the students' strengths, and how the process of learning can go, and open that. You can make a systematic discovery of the strengths of the professor, a systematic discovery of the strengths of the students, a systematic discovery of the interests of all the students, and a systematic discovery of the best methodologies to teach and to learn, for example. And then you make a step-by-step appreciative inquiry: discovery, dream, design, and testing. So the discovery would be systematically discover and understand the student's strengths and the professor's strengths. The dream is that how I imagine the best way to learn or to teach. And then the design. I have to assign teams and say, okay, I dreamt like this. This is the content of my dreams. How can I design in a practical way the methodologies to put in practice of what I dreamed about? And then I can have the destiny. I have to elaborate a specific project to implement what I dreamed and what I designed. I didn't do an appreciative inquiry per se, but I did. Yes, there is another thing which is not appreciative inquiry, which I call the situational leadership model for supervisors, particularly in master's degree and PhD degree. For example, so just to give you an idea, the situational leadership model allows you to assess in detail the technical competencies of the student, the behavioral competencies of the student, which provides me what we call the level of maturity of the students. And together with the level of maturity, I can understand what is the most appropriate leadership style for the professor. And then based on that, you have 4 leadership styles. It will help you design the mentoring process of the whole PhD. For example, I have 4 students with 4 different levels of maturity. I have the brightest one and I have the least brightest one. So the leadership style will be different because they have different levels. So which are these levels? I have to learn each leadership style, for example, and the way I will make them mentoring will be different in frequency and the type of competency I'm going to teach them. So all the mentoring transform the supervision in a mentoring program, in a long-term mentoring program for a master's degree or for a PhD degree. Specifically, not an appreciative inquiry, but it is a leadership training program, not just for the professor, transforming the role of the professor as a coach and mentor, but also the student. Because if you have a systematic planning and mentoring planning, what research shows is that the performance of the students, wow, goes up very, very fast. Because they feel they have a systematic feedback. And that's my experience, and the experiences of systematic feedback is that the performance goes up. Not only scientific performance, knowledge, not scientific knowledge, but also research projects going on. They perform better because they have systematic feedback. I was in London. One of the most common complaints about students that I can't meet with my supervisor. I'm 2 months running around him. So there is a lot of difficulties, a lot of anxiety, a lot of fear about PhD students and master's students. So this is a very, very efficient way to help them, and also the relationship with the professor. Okay. So this is a different style.
Thank you very much, Dr. Ascenso. Unfortunately, we ran out of time. So if there are other questions, maybe we can ask after the meeting. Thank you very much.